My job, as assigned by the organizers, was to try and discuss how emergency and perioperative care helps in bridging the gap in patient care. This is in line with the theme of improving access to anesthesia and critical care for all Ugandans, and what are the challenges and opportunities. So I hope I do some justice with this. And yes, my name is Professor Luggya. I happen to sit at the Department of Anesthesia at Makerere University, and retired rugby player. He's in history. So what's the reality we have about our hospitals? The journey from the emergency room to the surgery unit to the recovery room is very, very fragmented and often operates in a silo, yet it's very, very significant in outcomes of the patients. There are very many gaps we have. We are still in the colonial era of 3B medicine, 3B surgery, and then you go to post-operative units which are not clear in the emergency room, and then somehow if you end up on the cold wards, you'll basically have a very fragmented service of care. So how do you bridge these gaps? And because these gaps, time is money, time is life. So the quicker you intervene, the better. And my key points are going to be just define the emergency care perioperative continuum and brief overview by context in the region and Africa, which still is plagued by limited resources, referral delays, staffing gaps, and the commonly used term is LMICs, which we're very familiar with. But there's hope for Uganda. Apparently, we're getting to middle income soon, so we hope some of these things will be addressed. I'll discuss the current landscape, which is high morbidity, high mortality that occurs from the delays. And ideally, my purpose is to highlight the barriers, innovation strategies to integrate the emergency medical aspects, which is very key, pillar for anesthesia and also emergency medicine, but very key for integration for outcomes of patients that end up in theater. So what is the status in Africa? We have Sub-Saharan Africa, which has a high burden of surgical emergencies, trauma being the key aspect. Obstetrics complications are we're very fertile people, and so trauma and obstetrics are very key. And by default, the third peak of all these effects on admission in the hospital is sepsis, which is in line with the emergency pillar, theater pillar, and post-operative ICU pillar for the practice of anesthesia and emergency medicine. However, the access to timely safe surgery and anesthesia remains limited. We have so many gaps in our system: human resources, coordination, system understanding, leadership roles, and we have broader needs to have urgent innovations, as we cannot move in different silos. We have to grow as a specialty in the continuum of care of patients, that the service cannot be very good in the cold theaters of elective theaters, while in casualty and emergency rooms, they have a woeful service, which is they call austere environments, like some specialists described our casualty in Mulago. How do we bridge the gaps? So the barriers I'll try to highlight. What's the systemic gap that we have? We have limited infrastructure and equipment. We have inadequate theaters, inadequate monitoring tools. Oxygen supply is still a good vision in the papers in Ministry of Health, but each regional referral should have, ideally by 2019, have had an oxygen plant with piping and an ICU and hopefully an HDU, but I don't know where that has reached. If Professor Kwizera is here, who's on the committee, is part of that, but we have those gaps. Referral and access delays. We have long transport times, poor communication between facilities. We have people using their cars to transport patients who are in need of emergencies, which leaves very big gaps of care. Staffing gaps. The low anesthesia provider population ratio in Uganda is very significant. We still are in very big need of this gap to be covered. And we rely on the non-physician cadres, which is a stopgap measure that helps cover all the resources, but obviously has a knock-on effect in the very complicated and advanced emergency cases. The fragmented emergency pathways, we have very weak integration, like I said, between emergency, surgical, and critical care services. They almost operate independent of each other. Getting an ICU admission I'll give an example where I work in Mulago, is you have to make 3 different calls, first from the surgeon to the critical care person, then they look for the anesthesiologist on duty, come and admit. By the time all this is done, the neurosurgeon will say, I need a CT scan, and the admitting doctor will say, I can't admit without a CT scan. So there are different challenges you have. What's Uganda's burden? We have a huge burden of trauma. I think in 2008, the WHO statistics showed we were the 2nd highest country with road traffic accident. Obstetric emergencies remain key, and sepsis does account for most emergency surgical deaths. So it's not, as much as we try to do something, we still have the knock-on death in the 3rd trimode of trauma, sepsis, obstetrics, because of delayed intervention, increased morbidity, and septic death. We lack functional theaters, operating theaters in all regional referral hospitals. This is very obvious that I think Dr. Tindi remembers the 2010 accident we had, where anesthetic officers were going to bury their colleague in, I think, Uganda or Kamuli, and they got an accident. And we were trying to get active all the hospitals on the road to Kampala, but they reached Uganda, it was closed. It had never been used, the theater. They reached Jinja, the people on duty had gone on holiday, and there were 6 or 7 critically ill patients, trauma chests, head injuries. These are part of our staff. We had to wait for them to come all the way to Mulago, where they got the first service of surgery, chest tubes, intervention. So we have challenges, and yet Jinja Regional Referral is a very big hospital. So some of the AOs retired after that, after they recovered, but the challenge is that we lost a huge number of them. And that shows how bad our referral system is. And as much as we have the structure, functionality remains very key. I thought I'd talk about a study done in 2019 by the team from Harvard and Barara University, where they assessed hospital walkthroughs and they interviewed hospital directors. This was just to assess surgical burden and use in the hospitals. And they assessed 5 domains: infrastructure, service delivery, workforce information management, and financing. And the operation was described as when a patient comes, is there an incision done? Is there an excision done? Tissue manipulation that needed regional anesthesia or general anesthesia. So this is 2019, and when it was published, and they needed to get into an operating room just to highlight the burden. And again, you can see the regional referrals. I don't know if this is clear, but like Atatur had 0 functioning theaters, 0 general surgery, 0 obstetrics, 0 orthopedics, so 0 across the board. This is a regional referral in the East. Gombe had 1 functioning theater, no obstetrics, no other specialties, general surgery and OBGYN. Mbara was the highest, obviously, and followed by Mbale at 550. So they did a 30-day operation volume, and Mbara had 570 surgeries done in that 30 days. But what was significant is, say, the lack of other specialties, which was key for me, was orthopedics line, almost 0 across board, and the functionality of the theaters kept opening the eyes. You have a regional referral which has 4 theaters, and that's the biggest, which is Mbara Hospital, and had functionality. Masaka, which had 5, had less functionality. It has 5 theaters, but they have 294 in the time Mbara did 570 with lesser theaters. So that showed the burden. But what did they find out? They found out the biggest surgeries were obstetrics and gynecology surgeries, which accounted for 68%, and then general surgery. And in the general surgery, they found out that again, C-section was the highest ranked at 58, and laparotomy for excision and angiography were 7 and 5%. So the conclusion is what I think we should take home before we even go further. There's a detailed understanding of case volume and distribution is essential in facilitating targeted interventions, which we hope can get us to increase in the continuum of interaction from the emergency room to the OR to the ICU. and that the main driver of operating volume in Uganda is the number of fully trained senior anesthetic officer providers. Cesarean sections still continue to dominate the case mix in Uganda, and investment in infrastructure and improvements in operational volume are correlated in terms of what's the outcome. So the last one was the most important one. There's critical need to increase the number of trained surgeons, anesthesiologists, and other professions in order to meet the surgical volume target, which Uganda needs. And human resources still remains the most important critical component. In as much as all the innovative strategies do play a part, you need the presence of staff and human resource. So that already shows a burden of significant surgery cases that we have to face, and that's where by default we plug in as anesthesia. The current landscape I'll turn it down now to the bottom of the triangle where we'll talk about Uganda. We have trauma obstetrics again showing up as our primary issues, late presentation and poor operative optimization. We have a poor health-seeking behavior where people can wait with whatever surgical conditions they have and will report on Monday. Those who work in Mulago know this. The whole weekend will be quiet, and then you'll find someone with a chronic subdural walking in on Monday and says, I had to take the weekend off with the family, or like very bad IO. So sometimes some of our presentations are poor, but in as much as the system-based, they're also patient-based. The gaps, again, that I'm trying to point out in this talk is how do we sync the emergency departments, operating theaters, and ICUs, because the time delays in those areas are very, very significant. And by default, that time causes increased morbidity and mortality. I'll try to delve into the emergency surgical statistics. And there was a study done in Jinja where they found that 10.6% of individuals in Uganda that they were surveyed, it was a household survey, have one or more conditions that required surgical intervention. And the two emergency units in the 10-year period, which I think Jinja Referral and somewhere in the east, they found 22.5% were emergency surgical patients, and the most urgent surgical presentation were fractures, 30.9, which points to the trauma, lacerations, 29.6, and abscesses. This was done in the non-physician clinicians by outcomes of patients in the Ugandan EDs. It was a 2025 July study. And in the further statistics that they showed, so in 2023, we had 4,806 road traffic accidents. This was from Uganda Police Force. And that's the recorded traffic, because the problem, lack of registry also leaves a gap. We don't have the unrecorded patients that don't reach the hospital. What the police gets is clean data from the hospitals. There are people who die in between the delivery to the hospital. And in 2024, this increased to 5,104 deaths alone in Uganda from trauma. The serious injuries, for me, is the key factor, the morbidity that it does away from the mortalities. You have 16,736 people who are maimed, fractured, non-functional for almost a year or two, depending on how they present and what they presented. The minor injuries still are there, but the minor injuries are less, to around 3,106. So that means we have very high level trauma and very serious trauma damages presenting to us, because if the minor injuries are 3,100 and the serious ones almost 6 to 8 times more, means the burden is on the people in the ED, in the theaters, and in the ICUs by knock-on and by default. So trauma does remain a significant burden, and it's the assessment report from the Emergency Medical Services between 20 and 2023 showed there is the incidence of patients involved in accidents, so 176 per 1,000 patients. There was a decline from 385. However, that is still high above the WHO recommended number. And the mortality did reduce, but there's still lots of work to do. We have already seen we have very high numbers of severe presentations of 16,000 coming to the ED. I thought I'd do a small slide about the epidemiology of trauma to understand across board. So trauma is something that cuts across middle income, top income, and us, the low income, but it helps if you understand the gravity of it. I call it the silent epidemic because it significantly outsurpasses all the infectious disease deaths combined of malaria, TB, and HIV. But that's something not everyone talks about. And you can see 10 years ago it was 3,700 deaths. It's increased to 4,800 as per 2023. So we are on a trajectory of continuous presence of these patients in our EDs, whether we like it or not. And the best approach is to have strategies to improve this. The permanent disability is 3 times more the mortality rate. So in as much as, like you said, you have mortality rate of 4,800, but the permanent disability for those 16,800 people renders some people and the public not of any functionality anymore. So yes, it does have a knock-on effect, and it also comes back to the talk where our timely intervention of integrating these hospital systems is key between emergency medicine, operation services, and ICU services. The risk factors, this is all epidemiology, but I'll just highlight it, is exposure, the amount of movement and travel. The need for people to move from the villages to the countries means that there's more demand for people to look for money, jobs, and stuff. And in so doing, some bit of safety will be thrown out the window. I wanted to talk about the demographic factors because then we'll understand there's some work we have done with trauma and injury disabilities where we're doing the 10-year trend from 2002, to 2050. So we started from 2000, where our population was just around 20 million, and you can see the projected population to 2050 is going to be 100 million. So we are just how many years away? 25 years away, and we are at 2025 is where it's exactly supposed to be, because we're at 47 million now. So we're here now, and basically we're going to get to the 100 million mark in the next 25 years. And what is the key statistic for us to understand? It's 56% of our population, as per 2012, was the children below 18 years, and these are the youthful people now. Key for the take-home, why we need to understand among trauma obstetrics and being a challenge is the statistics from URA about motor vehicles purchase and cars. So you can see the red is the automobiles, the cars. So they all started at the same place in 2002. There were 10,000 purchases per 11,600, and they were almost similar. In 10 years, the motorcycles have overly doubled, and the cars are still staying below 10,000. Yeah. So without a doubt, this is continuous presence of patients in the hospital, and we need to work around that. So the survey in the Uganda Radio Network, which was in 2023, showed we had 13 deaths per day, 13 people dying in Kampala. And this has increased from 2000. So the death went there's a slight reduction from 2022 to 2023. And motorcycles, again, still are part of our main key issues. I will move on to obstetrics from this, because the trauma bit is what was the main key point for me for the emergency presentations in the emergency unit. And in Ginger regional referral, they showed that 40% of the laboring women that were received had very adverse neonatal outcomes. Now, this is maternal and pediatric outcomes that affect the patients. And neonatal ICU admissions were 27.6%, low APGAR scores were at 11.3%, early onset neonatal sepsis was at 6.8%, and a 2.3% neonatal death. We have a Uganda institutional mortality rate, which still remains very high, and from 93 to 86 deaths per 100,000 live births between 2021 and 2023. So our mortality rate in 2006 was 671 deaths per 100,000. It's slightly dropping, but still key for dropping it below acceptable standards is the integration of care between the emergency room and the emergency care service providers, who are the medical services that stabilize the patient, into operating rooms and theaters. So what is the gap that I'm trying to talk about? We have 3 different challenges. We have the pre-hospital delay, which is been recognized by the Ministry of Health. They started the 4th department, which is, I think in 2021 was fully functional as the EMS department, which is a tick on their side. They realized pre-hospital is as important as getting the in-hospital cover. So the EMS department is new in the Ministry of Health, fully fully represented from the ministry to the lower levels, district hospitals. There is a policy in 2022 that came out, and that has covered the administrative aspects of care. The in-hospital is ideally where the challenge for most of the members here is poor communication between EDs, theater and ICU teams. I can't belabor this again. We already, even at National Referral, we still have gaps in terms of smooth transition of patients who end up being dumped back to the trauma unit and have nowhere to go. ICU is not taking them up. So the challenges where there's care affected. Perioperative period is, we have no standardized pathways, but also multidisciplinary coordination, especially with pronounced PACUs. I think one of the students in the department did a study on PACU outcomes. I think it was a 20 or something, but it found out significant statistics that are clearly glaring, just even in national referral. Postoperative care, we have a limited critical care capacity, which is key. The fact that it's also the Intensive Care Society of Uganda conference. Why does it matter? Why are we all up in all these discussions? It reduces mortality, is the message I think we should take home. Patient outcomes and efficiency. The disability is reduced, especially for orthopedic patients, the neuro patients. The timely intervention for the surgeries reduces disability and functionality of the patients, improving their discharge outcomes. Strength of teamwork is also key, and resources use is very important. Most people will say it's very expensive to run the ED and have a functional ICU, but what's expense vis-a-vis high mortality rates and maximum deaths? It defeats the purpose of what we're trying to do as a society. I was reading about the cataract surgeries in India, where the India is 20 times higher in the terms of cataract surgery compared to America and Europe and China, which are bigger than them. And how do they address this? The people who ophthalmologists decided to tell the hospitals they're too expensive, and they went out and rented apartments where they stayed at the top floor, and the down floor was the operating room and ophthalmology clinic. And now they have the highest number, this is 30 years down the road, highest number of cataract surgeries, and yet the burden is higher in the US and China. So there are things we should think about outside the box of why we are trying to align with improved universal health coverage, WHO surgical care initiative, and ideally building resilient health systems, because I keep telling people we are all statistics of death every time we get in a car outside Kampala. Yeah, on the roads, the trauma, improving that service outside Kampala is important, because assuming that you're comfortable in the private hospitals and Mulago, and then you get an accident in Jinja, and then the people in Jinja can't do a basic chest tube to save you. So we are all like moving statistics in all this. And what are the strategies to bridge these gaps? We have system protocols, which is where the AU comes in. They'll improve integrated perioperative pathways. Emergency Care Society having these TAT guidelines, triage and transfer tools are already done in the Ministry of Health. In Uganda, TAT guidelines are there. Checklists are very key. The more you do some things by checklist orientation, the more you get better and skilled at it. Communication and teamwork is good, and part of it is improved with the new EMS department, where now at least transferring a patient from an outside facility to Jinja is improved in terms of properly ISBA delivery of patients to the person at the recipient side. Those days you'd be seated and say, oh, we brought 5 patients from Jinja or something. So the closed loop communication in emergencies is key. And by default, emergency medicine is still growing, but it's growing from anesthesia and critical care. So that closed loop communication improves safety and delivery of patients. Capacity building is key. We still churn out the quality students at all the programs, which is Mbara University, Busitema, Makere, and all these other places that train the critical care service providers. Resource optimization is key. Surgical checklists from WHO should be key at all points of service. If I did a quick ask about how many people actually do surgical checklists, even in Kampala, you'd see a different number, because we take some things for granted and you're like, we don't have to do this. It's obvious. So even this becomes a habit that we pick up and basically affects outcomes of the patient. Strengthening recovery and HDU units. The ministry has proposed all regional referrals to have a functional HDU and ICU and oxygen. Its implementation is a different thing, and the idea is very welcome, but that's stuff that we have to strengthen in all the 14 or 15 regional referral hospitals to reduce the burden of death, but also increase quality of care the patients get at those hospitals. Innovations and best practices, these are all internal systems that each hospital can do. Nurse-led perioperative pathways are very key. The numbers we have are the nurses, and if you train them properly in surgical checklists and operational checklists, things that you need to do very well, it improves outcomes. Telemedicine or e-consults for emergency cases is key. We cannot emphasize enough the fact that times have changed. You can be in Soroti and you call someone in Kampala or Mbale and say, fine, I have ABCD challenges. How do I address this? And they can guide you on that. And we've gone ahead of having surgeons in the US helping us operate in Chabiru and even in Mulago, where by default you're talking about the stuff you're seeing here, and the surgeon is in the US guiding on how to do very complex cases. So that also can be something we can integrate. Regional examples are key. Uganda, Kenya, South Africa. Kenya did the 45 regional centers, where each regional center has a dialysis unit, HDU, ICU, and consultants of all specialties. It's something we can pick up in Uganda. I don't know if it's yet in plan, but it will be that. Leadership is an important factor, and in integrating these things. And there's surgical, obstetric, and anesthesia, NSOPs. I think Mary is in that project with the Ministry of Health. But most importantly, you have to have leaders. So this is a small discussion we're having with the Commissioner of Health Services when you're doing health service interviews, and he's very passionate. The Commissioner of Clinical Services and Ministry of Health says he wants to start the project of emergency care, and he wrote it down, and I kind of kept it, and I've never gone back and seen him in like 6 months. But he's actually passionate about starting, on top of the NSOPs, feeding into the NSOPs, the emergency care operation and intensive care plan, which is something that is a good idea that we think we can roll on. I had put a case example of a 28-year-old mother, and this is for open discussion. I can leave it for maybe 5 minutes. A mother arrives with ruptured uterus, 3 hours delay from referral. Emergency surgery succeeds, but she dies due to lack of monitoring. How would you manage this in your settings? And what do you think are key points to address, to take home here? Zahra, you want to try? She has died. Discharged through the mortuary. So we're discussing. So there's discussing the challenges and what we think can improve. Because I've given a very basic scenario. What are the first 3 things you see that point out here? Yeah? Timely referral, yes. There's a delay, isn't it? In as much as that already shows a communication gap for the patient coming to the unit. And in as much as the person did get the service, the outcome was death of both the mother and the child. So these are simple things that happen usually, but morbidity and mortality meetings are key in addressing some of these things. I will try and summarize with, so bridging the gap can be addressed in different ways. You have to strengthen the emergency preparedness. And emergency units are most important units before you even get disposition of care to the theater or casualty. And part of the reasons why I took a step back to focus on emergency medicine, because it's the face of the hospital, but also it's the point that you have most integration of safety, because there's no use of you having a brain dead patient for a bar hole, yet you would have done some interesting stuff to relieve the patient's condition. Invest in human resource and training. This is being done maybe at different skills, but we should have a conveyor belt of improving the numbers of all the anesthesia specialists, EM specialists, and that can improve the service delivery. And build an efficient referral and communication system, to reduce the delays, which is part of the EMS KPIs of the ministry, and those are different works happening. And multidisciplinary teamwork is key. And NSOPs, ECOIP, all these things are showing that the direction of the ministry and most of the service providers and associations is to improve integration of this service so that it's no longer silo operations, but continuum of care with multidisciplinary involvement. So the goal, ideal, is timely, safe, equitable care for every patient, everywhere. Lastly, the way forward would be that, like, every emergency patient deserves a seamless journey, like from the door to discharge, and bridging the gap is key. I already emphasized every time you get into a car and leave Mukono, your old statistics of death, if you get an accident and you don't have timely care. So emphasize improvement of care in your settings, emphasize structure approach, emphasize protocolized care, emphasize checklists in all the hospitals you work at, because that's very key in improving that. So my key takeaway in summary is to know that integration saves lives and commit to your institutional change in small ways. If you are in Soroti, try to improve the fact that you do a checklist and do, say, ATLs and training for your staff. And with that, I'd like to thank you for your time, and I'd acknowledge the conference organizers, SAU and ICU, and the Department of Anesthesia, which happens to host me for my address. Thank you.
Thank you very much, Dr. Stone, for your presentation. So I'm going to take one or two questions for the presenter, and then we'll move on to the next presentation. So any questions?